Over to you, Magda.
Thank you very much, Kerry-Ann and Christine. Thank you everybody for attending tonight. This is the first of our series on domestic and family violence and the information sharing schemes. And I'm really happy to be here with my wonderful colleague Marina Malcolm, and together we'll be facilitating this webinar. We welcome you to ask us questions, which we'll hopefully take at the end of the session. I'd like to also say thank you to Christine McMahon and Kerry-Ann Singleton, who've been amazing in helping us put this together and are always in the background helping put our slide decks and our presentations, polishing them up for us. So thank you for tonight. Now, tonight is about domestic and family an endemic problem in our society, and this is part of the program that has been established between the RACGP and the Department of Health and phase 2 of Safer Families. But before we get started, I'd like to welcome you all and acknowledge the traditional owners of the land from which we all gather today, and acknowledge that land that we're on was never ceded, and to pay our respects to elders past, present and emerging. And I'd like to also pay my respects to victim survivors who might be tonight participating here, because doctors are part of the community, and as members of the community we're all parts of families, members of families, and some of us have lived experience of family violence. And some of this might be triggering for some of you. It might bring back very, very sad, deep feelings. And if that does happen, then and you find that you are distressed by any of this, please feel free to remove yourself from the session, but also reach out for some help and seek some support from any one of us. I'm open for conversation and support, and also pathways for support through 1-800-RESPECT and Safe Steps, and also the Orange Door and Doctors for Doctors. So a bit about tonight. We are here to help you understand a little more about the new information sharing schemes, which were introduced in April of 2021, and they affect general practitioners here in Victoria in particular, because it's a Victorian initiative that we are now part of an information sharing entity group, which means that we not only need to identify and respond to family violence in our practice settings, but we also need to be able to collaborate with other service providers in family violence and collaborate across a period of time to better manage women and children who are victims of family violence. Now, where this all evolves from is from the Safer Families Centre of Research Excellence out of the University of Melbourne, which was funded federally and is a consortium now between the Royal University of Melbourne, Phoenix, Blue Knot Foundation, RACGP and the Women's Hospital. And phase 1 has all been about providing safe pathways for women who are victims of abuse in the primary care setting. And it's about enabling primary care practitioners, GPs and primary healthcare nurses to better manage family violence. And Marina will expand on that further. So what we hope that you'll get out of this, we hope that you learn a bit more about the information sharing schemes. Not everything will be delivered to you today. You'll learn more about it in our subsequent webinars, and some of this will be broken down and in greater detail in our subsequent webinars. So Marina, over to you.
I'm just going to have to get you to move the slides. Yep.
Oh yep, move the slides.
Oh,
or you
hang on. I've just lost the, I've got you, but I've lost the slides.
I'll bring it up. There we go. Yep.
There we go. Okay, I think I've got the, can I just get you to press on the start? Yeah, there it is. So how common is domestic and sexual violence? Well, it's really common. If you look at the numbers in Australia, 1 in 6 women have experienced physical or sexual violence by a current or a previous partner since the age of 15, whereas it's 1 in 16 men. and 1 in 4 women, so, you know, it's a quarter of women, have experienced emotional abuse by a current or a previous partner since the age of 15, compared to 1 in 6 men. And 1 in 5 women have experienced sexual violence since the age of 15. And so it's a really, really large problem. And as we can see, it's a problem that affects men and women, but mostly women. And so moving forward tonight, we'll be talking about it mostly in the context of violence against women, because it really is very much of a female experience problem. And this is seen from the key facts from the WHO. And they've certainly identified that 1/3 of women worldwide are struggling with violence. And so I think that this is important, this slide, because it really shows you that it's not just an Australian problem. This is a problem worldwide. It affects all cultures. It affects people from urban settings, rural settings, different socioeconomic settings, different levels of education. It really is a worldwide problem, and it's a major violation of women's human rights. If we're talking about intimate partner violence or family violence or domestic violence, we use them all a little bit interchangeably. You really have to sort of understand all the behaviours that it encompasses. So this is a good slide for that. So I think that historically, we have been very good at identifying physical violence and sexual abuse in the space of domestic violence. So physical violence is what I'm talking about in slapping, hitting, kicking, beating, using knives and guns, or the threats, that physical threat of physical violence. And sexual abuse as around forced intercourse, but also sexual coercion and reproductive coercion, where condoms are removed or birth control and contraception is not allowed. But I think you really have to understand that it also very, very much includes the psychological and the coercive control tactics. And all of these things work together around control. And so you really have to ask, or have your mind open and thinking about, you know, intimidation, humiliation, that belittling and harassment that goes on within relationships. And then also that really controlling behaviour, which isolates people from family and friends, but the monitoring of movements of male, of financial control, of control over money, visa abuse, and also sort of mental health and substance coercion. So you have to sort of see them all together as all being very much involved. And I use the I love a mnemonic, and I use the ACTS mnemonic. And so, you know, I like to ask my patients whether they're feeling afraid of their partner, and then I explore that if they say they are, if they're feeling controlled, if they're with the things in their day as being controlled, if they're threatened to being hurt, or if there's any slapping, hitting, kicking, or other physical things that hurt you. So what are the implications of family violence? Well, it really affects the individual and the whole family, and it has lifelong effects through from infancy, childhood, adolescence, and up to adulthood. And so, you know, it really does affect whole communities. You know, so you have to think about it within your consultation space around, you know, babies. We know about, you know, injury and things like that, but look for it in attachment, growth delays, neurobiological impairment. Think about it in the kids coming through with anxiety and PTSD and mood stuff, but also really disruptive behaviours, troubles at schools or troubles with friendships. Into adolescence, think about the conduct disorders and the substance abuse and the real risk-taking behaviours. And then in our adults coming through, you have to think about it in sort of personality disorders, all psychological presentations, chronic disease presentations, or if people have experienced relationship problems or abuse in their past. So if we're thinking about the many, many, many things that people can present with, you really have to be able to grade the risk. And so I wanted to highlight some of the higher risk behaviours that really have to alert you to take a closer look and understand that the woman is at high risk here. And so and I think some of them are obvious to us, but some less obvious. So, you know, if there's a strangulation or choking, it's extremely high risk. Assaulting while pregnant is very controlling and very high risk. Threatening to kill, obviously high risk. Unemployment increases the risk. But here I wanted to show that this really obsessive, jealous behavior is very high risk. And you can also see in there that controlling behaviors are in there. So these are very, very high risk situations. If there's recent separation, if the frequency is increasing in frequency and severity, it really has to have your alarm bells going. All the stalking, I think, you know, access to weapons. Ask about pets, whether the perpetrator has harmed pets or is threatening to harm pets. Sexual assault, self-harm, recent separation is a very high risk situation also, and drug and alcohol. So these are the things that really have to set your alarm bells going off.
Thanks, Marina. And so with the family violence reform, the Royal Commission on Family Violence resulted in working groups and recommendations that have resulted also in information sharing schemes changing to equip GPs to be able to share information outside of the context of the consultation room and collaborate with other providers and other service providers. And we are included now in the information sharing scheme entities. And the highest disclosure rate of any to any professional provider, healthcare provider, is made to a GP. So 1 in 10 women who present to a GP in over a course of a year will have experienced family violence or intimate partner violence. And 9 out of 10 will tell their GP if asked. And the simple questions are, you know, how are things at home? And do you ever feel scared or unsafe in your own home? And they're big questions, but they can open up that conversation. And we're encouraged now, as part of the legislation, to identify family violence and then to respond to it appropriately. So what we're going to talk about here is about the framework around how we can do this with the understanding that what we're trying to do is prevent deaths and prevent further harm. So the information sharing reforms for GPs are being rolled out in stages, and it takes a while for us all to understand what it really means. And we'll talk to you about the incremental changes that we can make in our own practice that will make things easier for us. And we'll be able to also not just share information with other information sharing entities, but we'll also be able to request information if we feel that there's a high level of risk with a patient. And as Marina indicated before, we need to be able to grade the level of risk. So is the risk a sort of a low, medium or high level of risk? And what Marina shared with you up there in the previous slide is high level of risk. And that is something that requires quite a bit of specialist attention and collaboration with other information sharing entities. Now, I'm going to play with you play here for you a small video, which explains to you the information sharing schemes that have been introduced.
Family violence has devastating consequences for women, children, families, and communities. On average, 1 woman a week is murdered in Australia by her current or former intimate partner. 1 in 6 women have experienced physical and or sexual violence by a cohabitating partner since the age of 15. Family violence is deeply gendered. The majority of perpetrators are men, and victim survivors are women and children. However, family violence occurs across all forms of family relationships and is not unique to any culture or specific community. That said, women who are marginalised and discriminated against because of their ethnicity, socioeconomic group, language, disability, sexuality, gender identity, religion and age experience additional barriers to accessing services. Children are present in 1/3 of family violence incidents in Victoria. In a family violence context, there are likely to be a range of coexisting wellbeing and safety issues arising for a child. Children who have been directly or indirectly exposed to family violence often experience the long-term effects of trauma, which can be carried into adulthood, resulting in a range of emotional, mental, and behavioural problems. All parts of the service system have an important role in promoting the wellbeing and safety of children and identifying and responding to family violence. In recognition of this, Victoria has introduced new reforms. The Family Violence Risk Assessment and Risk Management Framework has been redeveloped and is now known as the Family Violence Multi-Agency Risk Assessment and Management Framework, or MARAM. MARAM now includes a wider range of evidence-informed risk factors for different population groups. MARAM supports organisations across the service system to better understand their responsibilities in identifying family violence and undertaking family violence risk assessment and management, including information sharing and cross-agency collaboration. For the first time, a range of organisations will be prescribed under regulations and required to align their policies, procedures, practice guidance and tools with MARAM. Government departments and peak bodies will be supporting organisations to understand what this means for them. Introduced in February 2018, the Family Violence Information Sharing Scheme permits prescribed organisations to share information relevant to assessing and managing family violence risk, including information about the perpetrator. The Child Information Sharing Scheme permits authorised services that support children, young people and families to share information about a child or any other relevant person in order to promote the well-being or safety of all Victorian children. Providing more collaborative and coordinated services to all Victorian children as early as possible is key to promoting child well-being and safety, preventing harm and avoiding crises. The two information sharing schemes complement information sharing under existing legislation and make it easier for authorised services to share information to keep people safe. All three reforms are integral to promoting the well-being and safety of children and reducing family violence in Victoria. This is a shared responsibility across our service system. Each sector is required to collaborate, trust, and reinforce the work of others to ensure that women, children, and families are safe and well and free from violence.
And for more information on the MARAM, you can access it. Oh, sorry.
Family.
Yes, you can access the website from that information sharing website, and you can. The MARAM is a very dense document that will be broken down in this presentation in a simple slide that looks at the 4 pillars and the 10 responsibilities that we have as GPs, which are not really different to what we do with lives. If you've already looked at lives and done a course in family violence on identifying and managing women with family violence. But what is changing, and this is demonstrated in this particular slide, that we have existing information sharing schemes. We have existing legislation here, such as our mandatory reporting for child abuse and sexual abuse. And with the Child Information Sharing Scheme, information can be shared or requested to promote the well-being and safety of a child. And the key word here is the well-being. Once it was just the safety, now it's also about their well-being, how they're functioning at school, and their psychological well-being. And neglect is considered also part of the well-being. And this supports the earlier intervention without the threshold having to be reached for mandatory reporting. That was on child well-being issues and concerns without it necessarily having any aspect of it associated with sexual violence or even physical violence. Family Violence Information Sharing Scheme. This indicates that we can share information around victim survivors, women mostly, who we feel are at risk or who disclose to us that they're victims of family violence. And with their permission, ideally, when the risk is very low or medium for them in terms of if they're at risk of death, then we need to report this, and we need to let them know that we're going to report this. But if the risk is moderate to low, we can ask them for permission to share information with other services that will support them in their process as they seek support for themselves and their children. It might not be that they require intervention that's directly involved with the violence and taking them out of their home, but it's about supporting them over the journey through their life in that relationship, which they often stay with. And we might be in communication with other services over a period of time. They might ask information of us and we might ask information of them. So what is an information sharing entity? Well, an information sharing entity, there are different categories of them, but it's an organisation that's prescribed under the Family Violence Scheme and the Child Information Sharing Scheme to share information with other entities. And the other entities can include other information sharing entities and also risk assessment entities, which are RAEs. And they are usually the Child Protection Services and police services. So who can share information? Only those who are prescribed as ISEs, information sharing entities, and RAEs, and under the scheme of the Family Violence Information Scheme and Child Information Sharing Scheme. And so the different categories here are in the health workforce, and you can see here that public hospitals, maternal and child health, ambulance services, community health, alcohol and addiction and mental health services, and state-funded aged care have all been prescribed as information sharing services in phase 1 of the rollout of the information sharing scheme changes, and we're in phase 2. So GPs and nurses have entered this only as of April of last year. Up until that time, it wasn't required of us to share information. And of course, the justice sector, which is Victoria Police and Corrections and Courts, and also education workforces such as schools, kindergartens and long day care. So that's especially important for child information sharing. And human services such as specialist family violence services, child protection, care services, child and family services. So the justice sector and the human services usually fall under the auspices of the risk assessment entities also. So Marina, over to you.
So why are we involved here? You know, why are we information sharing? And the answer is that we're actually really central to making a massive difference around family violence at a community level for women. So other than friends or family, GPs are the most common, the most often person where a patient will disclose to us. So we have to be looking for it, we have to understand it, and we have to respond well to it because they're reaching to us. Community has an extremely high level of trust for GPs and GPs' advice. We have to think about it because there are often children in those homes. So 1/3 of people experiencing family violence will have a child in the home. And so, you know, if you're looking at the numbers, 80% of victim survivors will seek help from mainly their GP. So they go to health services, but we are the most common person that they go to. So that is why we're involved. And what is the benefit? The benefit is for our patients overwhelmingly. It's for their families. And it's for us to understand our patients better. So we have to really be aware about it. We have to know about it, and we have to use it, and we have to do everything that we can to enhance safety and the health of our patients. So that's why we're talking about it. So this is a bit of an infographic just to sort of help. I'm good with infographics. I really love the puzzle piece. I really understand that, you know, I understand when I have to get child protection services and when I have to mandatory report because there's a serious risk. So I really like the idea that the information services are the small of the puzzle piece underneath, where you're not meeting that mandatory reporting, but you are meeting the thresholds to assess risk for family violence and to optimise health and well-being for children. And if we can all work together to share that information, then our patients do better and we have a better understanding of our patients. So, but we are an information sharing entity, and you can only share with other information sharing entities. And so, as Magda's previous slide said, you know, it might be that we're talking to hospitals about it, schools or kinders about it, child maternal health nurses, we often have lots to do with them, mental health and community health services, and then moving into those other spaces like police, justice, addiction, housing, child and family services, family violence, so that we're all working together to build a bigger picture to assess risk and safety.
Great.
So what is the Family Violence Information Sharing Scheme, FVISS? So this is that puzzle piece that sits under the mandatory reporting of urgent risk. So it enables us to share information for family violence risk, and the threshold is in we're sharing information if we're working out about a risk assessment or a risk management in relation to both children and adults within that family violence situation. Yep. So the threshold, it has to be information sharing entity, and they have to be requesting information that will help assist with risk assessment and risk management of family violence. Next one, Magda. So who is asking us? Those information sharing entities. And in my practice, my receptionists have a list of them, my practice manager has a list of them, and I have a list of them. But you can always access, you know, the VicGov ISE list if you need. So it's people who are prescribed to share information sharing entities. And why are we sharing? Well, it really has to meet that threshold. Is the information we're requesting or is being asked of us to share, does it meet this threshold of managing and assessing family violence to adults and children? And so we can ask information of other places. So you can ask information or you can share information too. And what is about that threshold.
Mm-hmm. So the Child Information Sharing Scheme. So it enables sharing of information to promote the well-being or safety of a child or a group of children who are in a family setting or not in a family setting that are at risk of violence or not at risk of violence. So this goes beyond family violence. This also works independently of the Family Violence Act, and this becomes really important, I think, in school settings also, where certainly teachers now are also part of the information sharing entities. And there's an entire new program teaching and training teachers around identifying risks for children who are not thriving. So it's about really helping children thrive in our community. I think one of the key things about the information sharing schemes and the adjustments that have been made, it really demonstrates that there's a deep-seated belief that family violence and the well-being of children and safety of children is a community issue. And I think that really is displayed very well in the video that was shown earlier, that everyone that comes into contact at a professional level, at the health juncture of individuals, is in some way responsible for supporting people in need who are facing family violence or are victims, or in this case, children who are who are exposed to risk of either not thriving or of harm. So the information sharing entities are authorised to share information, and that was listed before, and we are now mandated really to share information where we feel that there's a high level of risk. And why? It's to promote the well-being or safety of children or a group of children, and it's to be proactive. So we can be proactive rather than wait for things to really deteriorate and say, oh, you know, now I absolutely have to because the child has presented with, you know, serious injuries. We can use our judgment also, and also have that conversation with others who are also involved with the child, and ask them if there has been any if there have been any other signs that might suggest that the child is at risk in ways. So we can be proactive. It includes concerns around physical, psychological, emotional, health, nourishment, supportive relationships, development and housing. So it's really broad. And what can be shared? Well, it could be information regarding, you know, anything that to assist provide the provision of better care. And one of the things that we're going to talk about in our subsequent webinars is how do we identify that the request for information is coming from a true source, that's an information sharing entity, and how we document that, and how we also deal with the issues of consent and whether or not we feel that that there, you know, if you feel uncertain about it, then it's best to ask someone who is a family violence service provider. Now, consent is not necessarily required if you're sharing information regarding a child at risk. Their slide with the puzzles showed you that where the bits are fitting into it. Now it sort of doesn't have to meet the mandatory requirements for us to share information. But where the child has a parent and the parent is not suspected of being the perpetrator, it's good practice to let the parent share with the parent your concerns and let them know that this is your intention. And so we're talking here about consent to share information under the schemes. And this is where our presentation will end tonight, even though there are a number of other slides beyond this that go into greater detail. And this, because we're going to talk about consent and documentation in webinar 4 in a lot of detail. And in our subsequent webinars, we're going to break down family violence information sharing and child information sharing and in greater detail. I think one of the things that we need to also consider is the role of the perpetrator. And the perpetrator in most cases is a male, and sometimes it could be a father or someone that's closely related to the mother, to the female that you're seeing, or to the person that you're seeing, because of course family violence affects not just women, but also in same-sex relationships and in LGBTI relationships also, because we know people who identify as LGBTI, and also in CULD and in First Nations people. So there are specific needs that each of these groups might have and intersectional issues there that we need to be really sensitive to. And when we talk about consenting to share information, we need to think also about how our patients identify, and certainly if they come from an ethnic minority group, there may be different conversations we need to have to explain what it is that we're about to exchange and share. When it comes to perpetrators, the Family Violence Act and the information sharing scheme has changed to permit us to share information regarding a perpetrator without seeking perpetrator consent. And that's a very big and new step. And that is because what they identified with the Royal Commission into Family Violence is that a lot of different information sharing entities in those categories, in each of those groups that we've looked at, held really key pieces of information, which if they had the opportunity to collaborate and share that information, the deaths of those women might not have occurred and the deaths of those children might not have occurred. And of course, the case that and the person who drove a lot of this was our own Rosie Batty, who instigated the National Royal Commission, and then we had our own here in Victoria. And of course, as a consequence of Rosie Batty's advocacy and that of other victim survivors and also coroners' inquests, we have come to the decision here in Victoria that sharing information regarding a perpetrator is in the best interests of women and children and victim survivors and can save lives. That's the ultimate purpose of this whole information sharing scheme change. So as you'll see, we move on with our subsequent slides to consent and how we manage things. So we'll go into a lot more detail further down the track. So I'm keen to ask if there are any questions, if anyone has any questions at this stage.
If you have any questions, just feel free to pop them in the box. You can do it under your name or under anonymous if you want.
Yeah, because a lot of this information might be new. If not, then we might go into a bit more detail on the MARAM and what the MARAM actually looks like.
Well, I just wanted to share that I used the child information sharing scheme this week for a patient. So just to give some context, and I used it not in the space of family violence. I used it in the space of an eating disorder and a rowing program at a local school. And so I was able to share with the local school that the participating in that rowing campaign was actually quite dangerous. And so I think that's a really a good example of when you use it when it's not in the family violence space. So it's got two places. You've got family violence where children are included, and then you've got child information sharing, which is about health and well-being. So it's nowhere near that mandatory reporting space of sexual or physical assault, but it's certainly in the well-being and safety space. And so I was able to share, and I was able to share without consent, but I spoke to the family and said, "Hey, I would like to discuss this with the school." And so I think that's it's good to get examples, I think.
So Marina, that's great. And what was it that you felt was your concern that raised it to that level for you in terms of, so sometimes or often we all deal with young people who have eating disorders in our rooms, and not many of us will collaborate with the school and talk to the school about the eating disorder necessarily. In fact, often we'll talk to the psychologist, but not to the school. So what was it that made you think that the school would benefit from knowing about this? Was there also some, learning issues or school conflict, relationship issues at school that were affecting her?
So there were multiple steps that got us to that point. So and actually even got us to the point of understanding that our symptoms were an eating disorder. And so there were a lot of issues about anxiety around school refusal, around a lot of gastrointestinal issues around anxiety, weight loss. And so it was actually quite a new diagnosis for the family, and the family were having a bit of trouble coming to terms and understanding that this was an eating disorder, and not a food intolerance, or that it was bigger. And although they just were having difficulty making the connection that she was actually seriously unwell. And so the school had already been involved, but but that next level of doing 8 sessions of rowing was not safe for her. And I wasn't sure how well the school was communicating that with the rowing team, because so I needed the school on board to say how are we going to get her to stop rowing. And so that were the steps that led us there. So it was a little bit of family coming to terms and understanding what was happening, school really knowing what was happening, and being very involved with all of the other great things around supporting her to get her to school. And then just that next step saying, well, the PE department needed to get on board also.
Great, thanks for that. I might recap on a couple of things here, and one of them is just as a follow-up from what you were just talking about here. It's who can I consult with or refer to, which is, part of the process that you just described. And so in terms of us, so this is, you're talking specifically about child information sharing, but on the larger sort of broader information sharing schemes, basically just reiterating that we can share information where it meets the requirements of the Family Violence Information Sharing Scheme, or we're permitted to share information proactively and voluntarily without receiving a request. We're permitted to make our own requests for information from other information sharing entities, so we can actually proactively ask from another information sharing entity. And we can share information that's relevant to managing and assessing the risk to victim survivors of family violence, the risk of an individual committing family violence, and to promote the well-being and safety of children. So, these are the services that we have that we can sort of flick to when we think, if I need more information, if I need support, and if my patient needs support, who can I refer them to, and how can I also find out more? So here's the Marram practice guides and the RACGP resources. I keep flicking my slides. The RACGP resources now are available, and there's a Children at Risk learning portal. So if you're ever in a situation where you find you need to you feel that the patient is at very high risk, you can call the police. Now, this is something hopefully none of us have to ever do, but where a woman says, I'm scared of going home, that requires us to know what to do with that information. And sometimes that's one of the reasons why doctors don't ask. So from the research that's been done to date by Kelsey Hegarty and a colleague of hers, Professor Tarzia at Melbourne Uni, 9 in 10 women will tell a GP when asked, just a simple question like, how are things at home? But 9 in 10 GPs won't ask. And that's because a lot of the time we don't know what to do with the information. And we also don't feel we've got time. And with the Information Sharing Act having changed, we're now in a position where I have to identify this, and we need to also build our skills. So, Marina, would you like to talk to this particular slide here around the family violence scheme and, like you just described the process you went through?
Yeah, so I think that, again, I think we're very good at understanding the mandatory supporting, but this is when it's the threshold underneath. And so I would use the Family Violence Information Sharing Scheme if I think my patient is experiencing family violence, or they've disclosed it to me, or I think my patient is perpetrating family violence, or it's been disclosed to me that they are. So that's the family violence information sharing, and that will affect adult women, usually adult males. It involves perpetrators, and it involves children. Then you've got the other scheme, which is the child information scheme. And that is the piece of the puzzle that fits underneath the mandatory reporting of children for physical and sexual assault. This is broader. This is around how, have I got some information that can enhance or increase the patient's well-being and safety? Can I gather information or share information about that? So the threshold there is around child well-being and safety. So your family violence includes children. Your children information sharing scheme includes children, but it might not have to do with family violence. It might be around anything that's affecting their well-being and safety. So there's a little bit of overlap, but they're also separate.
Right.
I hope that makes it clear to people. And that's why we talk about them being those puzzle pieces that sit under the mandatory reporting rules that are still there, that are still exactly the same, but these are the pieces underneath which allow us to share information so we can build a better picture, so that we understand risk, we can enhance safety and well-being, and all of the other information sharing entities can build the picture of a patient to support them better.
Yeah, that's great. And I think that one of the things that we have also that burdens GPs is that we're time poor, and these are really big questions that we're raising with our patients, and we're identifying problems that require time to clarify, time to evaluate, time to make these, to document, because we need good documentation. So I think one of the key things that we also need to consider is how we manage the information in portions and in parcels, so in subsequent consultations. So we can't always deal with it all in one go, because otherwise any one of these cases might take us an hour and a half or more. And so we part of what the program that we're going to be unfolding here is about assisting GPs to become equipped in terms of breaking this down in subsequent consultations, getting the practice ready, having the right sort of documentation templates, knowing where to seek information when you're not quite sure. So you might not be able to remember everything around the Information Sharing Acts, but you know that it exists, and you know that you've identified someone who's at high risk now, because you know what high risk looks like from the slide that we showed you. And so once you've connected those two things, it's about then what you do. And sometimes you're not going to have all the answers in one go. You might actually come to reaching that over stages and through several conversations. But knowing who to have those conversations with is what information sharing is all about. So sometimes it's about the victim survivor, and you might talk about a victim survivor by name, by disclosing them, but you might want to talk about them also anonymously. So you can use a lot of these services and talk to them anonymously to seek information around how they would recommend you deal with something that you're concerned about. So that sometimes is what Orange Door recommends also regarding child information sharing, and Child First, in fact. Child First will often take calls from people and give them advice around how to manage a child without it involving any other third parties. They're going to just assist the GP and help you determine what their interpretation of risk is for this case. So it's all about reaching out and collaborating with with other sectors of the community and other sectors of the health workforce and the justice system and the education system to be able to improve outcomes for women and children. Now, there's a question here in the Q&A. Okay, if I suspect physical abuse to a woman, but she denies it, what do I do? Well, I think, and another question here, are there any online services used specifically for family violence surveys currently for research, etc.? Well, could I answer that? I'll answer the first question, Latufa. Are there any online services used specifically for family violence service currently for research? There is through the Australian Institute of Family and Welfare. Although if you look at Safer Families website, if you just go into Safer Families Centre of Research Excellence, you'll see that there are opportunities and for research if that's what you're interested in, participating in research, or if you are looking at more resources and more information and references, you'll find a library of references that you can work from and work with. So that's the Safer Families Centre Research Excellence, or just if you put Safer Families, University of Melbourne, you'll find that. And in relation to the next question, if I suspect physical abuse to a woman, but she denies it, what do I do? So, Marina, would you like to answer that or take it?
So you've got to sort of break it down to what we talked about a little bit today. Okay. And so I think that you always have to be a very open, non-judgmental, empathetic person so that you're providing a situation where someone feels safe if they are going to disclose. Yep. And so that's the first thing. And then you've got to ask, I ask sort of open and then I funnel down. Yep. And I ask permission if I'm going to ask more sensitive questions, and then I would ask direct questions. So I would ask something sort of open to start with and say, COVID has been quite difficult for very many relationships. Can you tell me about your relationship, how things are going? Has it been difficult? Do you argue? Is there any conflict? And then if I say, I can notice that you've got some bruising on your legs, do you mind telling me about that? And then if there's a clear denial, I will say, I'm just actually going to ask you some really more personal questions. I'm wondering whether somebody has hurt you, and has anybody hurt you? And if I still have a denial, I can't move beyond that, because I'm giving, it's about allowing the female to be in control of somewhere in her space where she controls the information. So I will express that I'm worried. I will try and be open and gentle and judgmental and listen. And I will be direct, but gently and respectfully. But if I still have nothing, then I can't move forward, but I can provide a space that maybe she can come to, and I can bank it so that if I get another little bit along the way in a subsequent consult, I can say, hey, I'm really worried here. I remember last time when you had this and this and this. Is there something going on? Can I help you with it? And so that's the space that I open up. Because remember, in family violence information sharing, you cannot share information without any of the consent from a victim survivor. And so if you don't have that consent, if she's not ready to disclose, you cannot share information. Is that helpful?
Yeah, I think that was very helpful, Marina. I'd just like to add there that part of the MARAM, when we go into the MARAM and look at what the multi-agency risk assessment and management framework means, it really means central to this is victim survivor self-assessment. So if she deems that what's happening to her is not serious enough, there may be cultural reasons for it. There might be embarrassment about it. There might be also lack of trust. So it's about building trust and allowing the woman to share with you, as Marina was saying, what she's ready to share with. You can ask really big, broad, open questions. And sometimes what we can say to women whom we suspect are victims of violence is relationships can be under a lot of stress sometimes. And sometimes bad things can happen in relationships. And it can happen to any woman, and women feel embarrassed to talk about them. And I want you to know that if ever anything like that were happening to you, that I would be open to listening, and I would be, able to support you, or wanting to support you in whichever way you wanted the support to be given. And building that trust by letting them know that other women experience family violence and also don't want to talk about it. They're embarrassed and they feel like it is their fault. And culturally, or that might be one of the paradigms they work from and live within, and within their own community, disclosing something that's very private and very personal is like airing your dirty laundry. And we've all learned from way back in our own lives that you don't air your dirty laundry, and family violence falls into that category. So enabling women to talk about this, or victim survivors to talk about this, might take time. And what the statistics have shown is that even in a trusting relationship, it can take years before a woman finally discloses that she's a family violence victim survivor. And it can take anywhere from 8 to 15 years. And you wonder, why is it when I've had an established relationship that it's taken so long? But that's because the embarrassment and the shame, and opening the conversation. One of the other things is also, we talk about getting our practices ready, and being practice ready is also really about, I'll stop sharing, is really about having information in our waiting rooms and making that environment open to this kind of conversation. And we'll talk about also having that later in your practices, so that you can create an environment where people who come in feel that, oh, these doctors know about this and we can talk about this. So we're coming close to closing, and we'd love your feedback. We'd love comments. We would, our next session will be in September, and remember that there are 5 sessions that we are that we're delivering here, and each one will take us deeper into family violence information sharing. And the next session will be on the 8th of September. So we look forward to seeing you at that. And at that one, we're going to be talking family and domestic abuse, how to identify family and domestic abuse, and what your responsibilities are within your Information Sharing Act. Marina, anything you'd like to add?
I think that was all really. I don't really have anything else to add. Just, I suppose that we just really wanted you to understand how central we are to really making a difference in this space. And then if we skill up, we understand that we don't have to fix it in 15 minutes, that it takes time, and we work together with the person who's disclosed, and it's a journey that you take together. And that's sort of the main points about today. Other than obviously understanding information sharing and that it's new, and that we have to get our head around it because we're part of it, and because we can really help, because we're central to our patient and all those other services that they're linked in with.
Great. And there are 2 comments here that I'd like to respond to. Isabel D'Souza says, shame rather than embarrassment is the root cause. I agree. And being triggered about disclosure and how that might be used to further against the patient. That's a very good point, Isabel. And Daruba asks, are we going to get the slides? That will be helpful. Yes, we'll share the slides with you once we've gone through the entire deck, because the entire deck is actually quite long, and we'll make them accessible to you. And this is being recorded, so you can also have another look at this too. Great. Well, we thank you very much for coming, and we thank you very much for being participants in this, because we're all working towards, providing safer outcomes for women and victim survivors and children in the community. And it's our role, and patients have a great deal of trust in their GPs, and we have long-term relationships with our patients, and we are really pivotal in helping deal with this epidemic. So good night, everybody.